When a patient suffers from a severe lumbar disc herniation, the internal material of a spinal disc ruptures, compressing the adjacent nerve root. To map the mechanical damage, they are placed in an MRI scanner, which provides the evidence needed for a structural diagnosis. After a year of rest and non-surgical treatment, the body typically follows a predictable healing timeline. The herniated material is reabsorbed, the nerve compression is relieved, and the spinal structures return to their normal alignment. However, follow-up scans often reveal a mystery. The MRI shows a perfectly healed spine with no visible pathology at all, yet the patient remains in debilitating pain. This disconnect suggests the pain is no longer tied to the physical state of the vertebrae. The structures have been repaired, but the signaling pathways have transitioned into an autonomous error loop. This condition is known as central sensitization. It occurs when the nervous system remains in a persistent state of high alert, even after the original physical threat has vanished. The initial disc rupture flooded the nerve root with pro-inflammatory cytokines, proteins like IL-1 beta and TNF-alpha, initiating a chemical cascade that altered how the body processes sensation. In this diagram, chemical signals trigger neuroimmune activation in the dorsal horn. Reactive microglia cause constant spinal hyperexcitability. These amplified signals travel upward to panel C, reorganizing networks in the prefrontal cortex and thalamus. The brain builds a permanent alarm system. This leads to kinesiophobia, an overwhelming fear that any movement will damage the spine. It is a logical response to an unreliable alarm system. Unfortunately, avoiding activity reinforces this sensitivity. Without the input of healthy movement, the brain's threat detection system stays locked in its hyperreactive state, worsening the symptoms. The patient becomes trapped. Their own natural urge to protect their body from pain ensures that the biological mechanisms driving the pain never get the chance to reset. For most people, movement naturally suppresses pain. This is exercise-induced hypoalgesia, a process where physical effort triggers the release of endogenous chemicals that dull discomfort. In sensitized patients, this process is reversed. Because their nervous system is primed for threat, exercise initially causes the pain to flare up, confirming their worst fears. Breaking this cycle requires pain neuroscience education. The patient learns to reinterpret these flares not as signs of new tissue damage, but as the misfiring of a hypersensitive nervous system. This knowledge allows them to begin time-contingent exercise. Instead of stopping when it hurts, the patient commits to a specific duration of activity, regardless of the signals their brain is sending. This isn't training for strength or flexibility. It is a direct psychological intervention designed to habituate the brain to movement and dismantle the fear avoidance cycle. While the patient focuses on the physical repetitions, a series of invisible chemical changes begins to take place within their neural pathways. Moderate intensity exercise stimulates descending inhibitory networks, activating the left dorsolateral prefrontal cortex, or DLPFC. It works with the anterior insula to coordinate a unified signal. These signals travel down the spinal cord, suppressing pro-inflammatory cytokines where the dorsal horn glitch began. Through weeks of repeated signaling, the patient systematically lowers their nervous system's baseline sensitivity. They are essentially recalibrating the threshold for what the brain considers a threat. Controlled movement serves as the biological trigger that reactivates the brain's internal pain management systems, providing a physical solution to a neurological error. The discovery of central sensitization changes the standard approach to back care, moving beyond the traditional reliance on surgery and long-term rest. When the primary driver of pain is nociplastic, originating in the nervous system's processing rather than the vertebrae, structural operations cannot solve the problem. This makes exercise a highly targeted neurobiological intervention, a prescriptive tool used to modify the central nervous system's reactivity. Recovery involves moving through these false alarms. By consistently exercising despite the discomfort, the patient provides the brain with the evidence it needs to feel safe again.